Part C. In this part of the test, you'll hear 2 different extracts. In each extract, you'll hear health professionals talking about aspects of their work. For questions 31 to 42, choose the answer A, B or C, which fits best according to what you hear. Complete your answers as you listen. Now look at Extract 1. Extract 1. Questions 31 to 36. You hear a microbiologist called Dr. Jane Finn giving a presentation about the overuse of antibiotics. You now have 90 seconds to read questions 31 to 36.
My name's Dr. Jane Finn and I'm a microbiologist. I'm talking today about the overuse of antibiotics, or antimicrobials as they're often called, and the serious dangers this poses for the future. We're all familiar with the threat of a post-antibiotic era in medicine. But how did we get to this point? Well, in the decade up to 2010, we saw a staggering increase of 36% in antibiotic use worldwide. As more and more global citizens were able to access them, usually online, we saw uncontrolled consumption during that period. Although recent media stories suggest the general public has finally got the message that antibiotics should be used sparingly, there's still a hard core who want them prescribed for everything. Doctors are now better at resisting their demands, however, for example when the problem's viral rather than bacterial. This has improved things. For instance, there's been a fall recorded in the overall amount of antibiotics prescribed in the UK in a given 4-year period. At first sight, that's welcome news. The data shows that this decrease hasn't had a negative impact on patients with common infections like pneumonia, but we simply don't know yet if it's made any impression on rates of antibiotic resistance. Other data shows that GPs have reduced the amount of antibiotics they prescribe by 13% over this period. Dentists have also reduced their prescriptions by an impressive 20%, but the figure for hospitals is much lower. So it's not an equally distributed decrease, so the picture's more complicated than it may at first appear. Something else complicating the picture is a widely reported medical research paper published recently. This suggested that short courses of antibiotics work just as well to treat most bugs as the traditional longer courses of a week or so. Those conducting trials suggested that there's insufficient data to prove that short courses encourage antibiotic resistance, and argued that it's using antibiotics for longer than necessary which increases this risk. The newspapers ran away with the story, however, and sent out mixed messages by suggesting it was okay for patients to stop treatment once they started feeling better. So I'd urge caution. After all, an improvement in symptoms doesn't mean that the underlying problem has been resolved. Also, we can't recommend widespread change on the basis of one article in a medical journal. In any case, as the original authors were careful to stress, the suggestions aren't appropriate for all bacteria-based illnesses, and TB was the example they gave. Indeed, some bugs have proved especially resistant to antibiotic treatment, and the best known is probably MRSA. This came to light when, as a life-threatening condition for patients hospitalised for other reasons, it became particularly tough to treat. MRSA bacteria is notorious for being able to survive for long periods on surfaces like floors, taps, and even fabric. And of course, the fact that healthcare facilities are visited by huge numbers of people means the bacteria spread easily. But studies show that healthcare-associated MRSA declined by about 50% between 1997 and 2011, thanks to things like new guidelines and targets, as well as ward-based contact control and meticulous disinfection procedures. This shows us that rather than relying on one single action, introducing various initiatives on several fronts can limit the impact of the infection. Turning to other areas of concern, let's look at antibiotics in agriculture and livestock rearing. People might be surprised to learn that worldwide, the overall quantity of antibiotics used in food production is now higher than the amount consumed by humans. Something which horrifies me is that antibiotics are consumed by animals as a matter of course, simply to prevent problems, or indeed to speed up their growth. This happens a lot in intensive farming, where animals are kept in confined conditions. We've known for years now that this overuse is directly related to resistance in humans, so there's obviously an urgent need for farmers to cut down. So, is there any progress to report? Well, though there's still serious work to be done in places, for example for manufacturers of antibiotics to stop discharging untreated waste products into watercourses and so on, it's not all doom and gloom. We're finding now that when doctors prescribe antibiotics, they're choosing narrow-spectrum ones. These are active only against specific bacteria and so cause less general resistance. And something which is being talked about excitedly in the pharmaceutical industry just now is a therapy which uses bacterial viruses called phages to treat infections, something which was first practiced about a century ago. Antibacterial therapies, whether phage or antibiotic-based, have advantages and disadvantages, and there's still a lot to be learned about the interactions between phage, bacteria, and human host. But maybe the time to take phage therapy seriously is rapidly approaching. Now, before I go on to the next thing,
Now look at Extract 2. Extract 2. Questions 37 to 42. You hear a rheumatologist called Michael Evans talking about osteoarthritis. You now have 90 seconds to read questions 37 to 42.
Hello, I'm Michael Evans. I want to tell you about the work we're doing on a condition that affects 1 in 10 people in this country, and that's osteoarthritis. Osteoarthritis typically affects the knees, hips or hands when the cartilage that lines the joints starts to wear away. So, how can we help patients with osteoarthritis? When I was at medical school, and that's a long time ago now, the theory was that it was due to wear and tear, an inevitable part of getting old. You still sometimes hear this, but it's one of the many myths about the condition. After all, we have teenagers who develop it, and every joint has the capacity for repair. So we should think of osteoarthritis as a situation where processes for tissue repair are overwhelmed by destructive processes that often relate to injury, weight, and mechanical load factors. But there are also other risk factors. Genetics may play an important role, and occupation makes a difference too, of course. Let's look at some more of the myths surrounding osteoarthritis. Osteoarthritis of the hands is an interesting case because this is one time you might think you can't put the blame on mechanical load factors. But you'd be wrong. There are actually circulating molecules that come from fat, and these influence the development of inflammation in joints. In fact, you're 30% more likely to get hand osteoarthritis if you're obese. And there are a couple of studies going on right now to test the theory that losing weight can have a positive effect on osteoarthritis in the hands. So what about knees? A lot of people say there are very high knee joint replacement rates in Australia, for example, because people do a lot of running in an attempt to keep fit. But this is another myth. In fact, studies show that for the majority of people, running's helpful in terms of stopping the onset of osteoarthritis. Though if you're a marathon runner, you do potentially place yourself at some risk. Now, if you've already got osteoarthritis and you want to take up running, the data's a bit conflicting. There are studies suggesting it can lead to exacerbations of the condition, but others suggest that patients who keep up their running do better at managing the condition than those who give it up. In fact, the sport that's often referred to as the knee surgeon's friend is netball. This is because it involves a lot of jumping, which puts pressure on the knee, which can cause a tear in the cruciate ligament, one of the main stabilising ligaments in the knee. This often leads to the development of knee osteoarthritis within 10 to 15 years. In the hope of preventing this, players may be encouraged to have surgery to repair the cruciate ligament. But in most cases, this is probably unnecessary, and it doesn't appear to change their long-term risk of developing osteoarthritis. The best way to prevent the problem arising is actually to teach players to jump and land in the right way. Unfortunately, whilst professional players get taught this neuromuscular technique, most ordinary players don't know about it. Now, let's move on to diagnosis. We have various imaging techniques, such as X-ray, and we have MRIs. For osteoarthritis of the knee, if an X-ray is going to show us anything at all, it must be a standing weight-bearing X-ray. But in most cases, it doesn't change what the doctor might do to the patient. We can diagnose by taking the history, assessing the symptoms, and examining the joint. And if someone of over 50 has an MRI scan, the likelihood is that it'll reveal a meniscal tear. That just happens as part and parcel of growing older, and it's not something that normally causes pain because a torn meniscus doesn't contain nerve fibres at that age. So it's just going to lead to unnecessary worry, and in most cases, intervention will do more harm than good. The next thing the patient wants to know is there a cure? Well, not yet. But recently there have been exciting developments in osteoarthritis treatment. People ask about stem cells, but at present they're unlikely to be any more helpful than a salt water injection into the knee because stem cell technology hasn't got far enough yet. But we're currently in the process of testing what we call disease-modifying osteoarthritis drugs that appear to be effective at regenerating joint tissues and reducing pain. And these will be injections a person gets into a joint maybe once every 12 months. But our main hope is that instead of turning to hip or knee replacements, patients can learn to control their condition through things like weight management and appropriate exercise.
Here are the answers for this part C listening. So for the question number 31, the answer is A, the ready availability of the drugs online. For question number 32, the answer is C, it doesn't reflect an even pattern of distribution. For question number 33, it's B, they are likely to leave readers confused. And question number 34, the answer is B, infection control requires a wide-ranging approach. Question number 35, the answer is they are routinely consumed by healthy animals. Question number 36 is selective use of antibiotics to target specific infections. And question number 37 is B, it may involve dealing with a range of problems. Question number 38 is to show how assumptions about it can be wrong. And question number 39 is B, running is probably effective as a means of preventing it. And question number 40 is B, this can be avoided by training players how to move correctly. And question number 41 is C, the results are unlikely to affect the treatment given. And question number 42 is A, new drugs may be able to restore joint tissues.